Fauntleroy, and on behalf of the nearly 90,000 alumni of this fantastic university, it is my pleasure as the Lehman College Alumni President to welcome you to this virtual event. On behalf of the Alumni Board, we hope that you and your loved ones are healthy and managing as well as possible during these challenging times. This is a virtual event, so this makes it possible for alumni, students, and friends from the Bronx and beyond to kind of spend some time together. With that said, I don't want to waste any time. I want to introduce you to the heroes among us who will share their stories and unique perspectives about being on the front lines of COVID-19. First is Dr. Captain Alicia Georges, who resume I can't read. And when I asked her for this whole book on it, she just said, just introduce me as a director of the nursing program. And if you know, that's the way she goes about her business. But we're so happy to feature her on this virtual front lines of COVID. So welcome, Dr. Georges. It's our pleasure. Next is Dr. Lellanie Martin, a native of Illinois and raised in Chicago, a 2015 graduate of Lehman's Family Nurse Practitioner Program. Dr. Martin is currently at Northwell Health, where she is the Transitional Care Manager and more specifically supervises patients back into their community after open heart surgery to avoid readmission. Then we have Darell Bishun, and I apologize if I'm saying that wrong, but Mr. Bishun is a Bronx native, raised in Yonkers, a recent 2020 graduate of Lehman's fully online RN to BSN program. Ms. Bishun is a staff nurse at Cedar Manor Nursing's long-term care and rehab facility in Austin, where he trains new staff, coordinates medication, treatments, and labs for over 50 residents. Next, we have Pauline Copeland, born in Jamaica, raised in the Bronx. She a graduate in 1994 and her MSN in 1999. She is currently the Director of Patient Services, the RAIN Home Attendant Services at Montefiore Medical Center. And she plans, organizes, and directs and enforces all client service policies and procedures. She ensures that the agency's strict adherence to its contract and licensing mandates are per HRA in New York State Department of Health. Then we have Kesha, and Kesha, I apologize if I get this wrong, but it's Kesha Durgaprasad. Kesha was born in Jamaica and raised in the Bronx. She's a graduate of BSN in '94 and her MS.
Born in Guyana, sorry.
Oh, I'm sorry. Born in Guyana, my apologies. And she is a graduate in '94 and her MSN in '99. She is also Director of Services, RAIN Home Attendant. I may have gotten that wrong, Kesha, but she provides.
Lawrence, you're mixing up Pauline and Kesha.
I see that. I see that. I apologize, Kesha. I'm going to take you off from mute and let you go ahead and introduce yourself, Kesha. My apologies.
Thank you. My name is Kesha Durgaprasad. I was born in Guyana and I was raised in the Bronx. I am a graduate of Lehman College Accelerated Nursing Program in 2019. I currently am a staff nurse at Jacoby Medical Center. I specialize in telemetry, CHF, and stroke monitoring.
Excellent. Thank you. Thank you, Kesha. Sorry about that.
It's okay.
And then last but not least, we have Rosa Sapadin, and she was born and raised in New York City, specifically the Bronx. She graduated, I'm actually reading this as me and Rosa was doing this in real time. She graduated from the BS of Nursing in 1980. She has her master's in 1998. And in 2013, graduated from the Lehman Family Nurse Practitioner Program. She is, if you don't mind, Rosa, can you come off from mute and just tell us what you're currently doing?
I currently work at a primary care family practice as a nurse practitioner, and I also work at Montefiore as an assistant director of nursing.
Excellent. See, we can make this happen in real time. Thank you. I appreciate it. First of all, just before I turn it over to Dr. Georges, because me and Dr. Georges are going to kind of tag team with the questions, but I just want to tell you that this is a personal interest of mine. simply because my wife was infected with COVID in early March, and my grandmother is 92 years old, and her grandmother rather is 92 years old. And so we really had to be strategic about my wife not being around her and communicating with the home health aide. And so my wife couldn't see her for about 3 months, just so we could be extra precautious. So I'm really interested in this topic and really interested in knowing what's happening on the front line. So without further ado, I'm going to turn this over to Dr. Georges, and her and I are going to go back and interview the panel.
Well, good afternoon to all of you who are currently on a webinar and those who will be looking at it or hearing later on. One of the gravest concerns that we've had in the borough of the Bronx, because we were the epicenter in New York City of the COVID-19, was the loss of lives. The loss of lives, the disability, the long-term care that many people who were affected and infected by the COVID-19 are now experiencing and will be experiencing for some time to come. Of grave concern to us in the Department of Nursing at Lehman College was the loss of 3 of our graduates. The second nurse to die in the city of New York graduated from our undergraduate program. The second nurse was a clinical specialist who had been very active in our Lehman College activities, had been one of our keynote speakers at graduation, and he passed away from COVID-19. And then the other person who was the president of our nursing society while he was a student also died of COVID-19. These folks were on the front line. They were right in the midst of those institutions that were providing care to people here in the borough of the Bronx. One was in a long-term care facility. The other 2 were in acute care hospitals in the Bronx. It behooves us to understand the criticality of this monstrous SARS-2, the COVID-19, but it behooves us to understand the sacrifices and those people on the front line, those essential workers who went in every day to take care of patients and then had to go home and take care of family. Some of them were in school, like Darell was one of my students. He was working 11:15 at night. I'll be talking to him. He's just coming from work and experiencing this. Pauline Copeland, the director of patient services for one of the largest agencies in this borough that cares for people who are aging. And she and her staff were there 7 days a week trying to manage the care for those older adults in our community. Lellanie Martin, who was out there doing contact tracing, trying to find out where is this coming from? What can we be doing? At the same time, she was trying to hold on to what's going on with her patients in community. Kesha, a brand new graduate, bombarded in the institution, thrown in and having to care for these patients. And Rosa Sapadin doing both things, trying to get folks who are mostly Latinx, trying to get across to them why they needed to be doing what they had to do, at the same time running to Monty and trying to make sure everybody got what they needed to. So this is critical, and that's why I want you to know our she rose and he rose from Lehman College Department of Nursing were right there in the forefront. So let me just say to everybody, if you can just tell us what your role was, because I've been running my mouth telling you, but tell your colleagues what it is that happened to you. So we're going to start as soon as I across the top. So Darell, Bishun, tell us.
Hi everyone, Darell here. My role during the pandemic, from the beginning, has been on the front lines, dedicated to working with residents in a long-term care facility, with the majority of them being elderly residents. The unit I worked on consisted of about 52 residents. So I was really tasked with still performing all of my nursing duties, such as medication and treatment administration, in addition to being very vigilant in addressing coronavirus as it began affecting the residents. Since we didn't have a unit manager, and many of the nurses and supervisors were leaving, I was ultimately tasked with making many decisions with regard to patient safety, as well as employing my own protocol on containing COVID. I had to collaborate with doctors who were no longer able to visit the residents physically, and utilize various telehealth tools in order to ensure that the residents and their changes in their condition were timely addressed. All of our doctors were required to take on additional shifts at various hospitals throughout New York. So it became really difficult to coordinate care and get verbal orders and document everything, all still while trying to maintain a safe unit for the residents, the LPN, and the 5 to 6 CNAs that I oversaw. So I had to really step up and advocate for the residents. I had to demand masks for them. I had to create a plan for patients who required assistance with meals or who were even aspiration risks to still be allowed into the day room so they can get constant monitoring because they wanted us to quarantine everyone. I had to closely follow the news as well as ensure that new Department of Health protocol for nursing homes were implemented because they sporadically sent memos from the Austin Department of Health to the New York Department of Health. So I had to provide basically in service to the CNA, so all the CNAs and the LPN, reminding them how to properly don and doff PPE. And just with regard to PPE, I had to essentially provide my own or create makeshift PPE. So that's really where I stood along that. With the residents who tested positive for COVID, I had to prioritize their care from frequently assessing them and doing everything I could do to ensure that they were comfortable. I monitored symptoms. I looked for trends. I even had to determine that diarrhea was a symptom before the CDC even recognized it. I had to stay in frequent contact with families who had questions that the care team, in addition to myself, had no answers to. And I was basically tasked with protocol where I couldn't call emergency services unless I got approval from a doctor. Emergency services even started to say that if they couldn't get to the facility within 20 minutes, they weren't going to come. And that was because we were a nursing home. So it was probably one of the hardest experiences I've had as a nurse for 2 years. I think one of my hardest days was when 2 of my patients coded at the same time and we ran out of supplies. So just working in a nursing home, I was really tasked with stepping up as an advocate, providing mental and emotional support to residents who were really seeing nonstop on the news that they were most susceptible, that nursing homes were in danger, and just seeing that there were outbreaks and casualties amongst their population. So that was basically my role.
Thanks, Darell. If we can have Pauline Copeland tell us.
Okay, so again, my name is Pauline Copeland. I'm the Director of Patient Services with RAIN. And as Mr. Fauntleroy mentioned before, I do some work with Montefiore, so I'm familiar with Rosa. Rosa and I know each other from Montefiore, and you know, as an ADN. So as in my role as Director of Patient Services with RAIN, I provide leadership to the staff, ensuring that the home attendants are staffing the cases. We have over 1,200 home attendants, and our case load is about almost 700 patients, I believe, right now. So we want to make sure those patients are provided for during the pandemic. You know, thankfully, at least I would say 95% of those home attendants did still go in to see those patients. So those are our real heroes, you know, on the front lines. And so all our patients, you know, didn't have to worry about whether they were going to get help or somebody to be there in spite of what was going on. The other thing that I do is to make sure they're provided with proper, appropriate PPE, face masks, face shields, gloves, gowns, make sure they have what they need while they're there in the patient's homes. We also have nurses who go out to supervise the home attendants. Are you hearing me? You can hear me? So, you know, at one point, I believe it was around March, we went remote. So everyone has been working remotely, either from home, and we're alternating coming into the office to manage everything. So nurses are also working remotely. So I have been tasked with writing policies and procedures to, for this whole new COVID experience, for the telephone visits from the nurses, for the home attendants as far as the PPE, what the requirements are, ensuring that they know what they need to, have while they're in the home, and any issues that have been happening. And we've been thankful that, many of our home attendants, we did have some come down with the virus, and we did lose some patients. We haven't lost any home attendants, but we did lose a few patients, but thankfully we're here. We've been supporting them. So that's part of my role, to provide support services to the home attendants, our staff that are here in the office. We have our intake person who's been here throughout the whole time. He's never worked remotely, and we're thankful that he's here as well. So these are the heroes. I know we're here to celebrate heroes, but the real heroes for me with RAIN is the home attendants. They go out there to see these patients daily, and they never complained, the majority of them. As far as inside the office, just advocating for a safe workplace in the office, ensuring that we're doing social distancing. Everyone is wearing masks while they're here. And I think that's basically it. With my work, I've been fortunate to see the side of home care. I've been fortunate to see the side of the hospital. And in the hospital, basically the same thing. We're providing support services, ensuring everyone has their proper PPE. Okay.
Thank you, Pauline. Rosa, can we hear from you? Unmute yourself, Rosa.
Okay, there it goes. Okay, my name is Rosa Sapadin, and I work at Montefiore Medical Center. I've been there 20 years. And I do the same job that Pauline does. And we direct the staff. We make sure everybody has adequate PPE. We make sure that we have adequate staff. We do a lot of rounding and make sure people are using the PPEs and that they're using it properly. We also are in charge of, we had to open some clinics to make room for all these COVID patients. And we had to make decisions on how to cohort them because there were so many patients in March and April. We also make sure that people were following the proper hand hygiene. And we also had to answer a lot of questions from the staff because there was a lot of fear going on, which was warranted, of course. And we made sure that we had a presence as administration, and we had to every day report how many COVID patients we have on a particular floor and what's going on. Luckily, the COVID, it's gone down a lot, but it looks like it's coming back up.
Mm-hmm.
So that's basically it.
Thanks, Rosa.
Thank you.
Dr. Martin. Mm-hmm.
Good afternoon, everyone, and thank you for having me. So I work for Northwell Health, and during the COVID-19 pandemic, our organization started deploying staff. So initially, I handled transitional care patients, and slowly but surely, we were watching the news, and then it just became an all-out, everyone, all hands on deck. So I was sent into a testing center, and our role there was to basically test everyone who came to us. And we tested a lot of people who were community workers, such as those at Rikers, police force, firefighters, nurses, other people on the front line. And also when we were there, our job was to kind of see who was stable enough to go home and who really needed to go up the street to the hospital. It was a difficult time because, as you know, they were only taking the sickest of the sick, and even that was contingent on many factors. So we were there, we were swabbing. And also what I noticed there is that providing a lot of emotional and mental support. People were going through it. They had whole family members who were infected. Some had people who died. There was somebody I ran into who had lost numerous family members. So that went on. So we would go in there, and it was kind of, it was scary at the time because the streets were dark. Nobody was out there. You're wondering, how deadly is this? Am I going to get it? So at night, I would go and I'm like, ooh, my throat feels a little tight. So the psychological effects of ourselves as well. And then once that started to change and they redeployed me back to my old unit, we did telehealth visits for the hospitals. on patients that were being discharged with COVID. That way it was like, okay, get them out of the hospital. We can manage them at home, make sure they have a pulse ox and just kind of keep the hospitals down. And so that part ended. We're assuming regular operations in our facility with the COVID testing, and I'm still working with the city hospitals testing COVID patients. And as we've seen, hopefully we don't get to where we were before, but you know, we can only do what we can do.
Thanks, Dr. Martin. Kesha.
Hi, hello. First, Dr. Georges, I would like to thank you for allowing me to be a part of this panel. There are many social disparities from systematic inequalities in obtaining healthcare that has affected our communities. So I started my nursing career at the beginning of this pandemic. I was fresh out of nursing school and I was so excited to finally start working as a real registered nurse. My first day at Jacobi Medical Center was March 9th of this year. 2 days later, on March 11th, the World Health Organization declared COVID-19 a global pandemic, and the Bronx was also declared an epicenter. A week later, I was assigned to the floor. One of my first days on my unit, 2 of my patients died within the same hour. As a new nurse, I was often so scared and terrified. I didn't know what to expect every day. I clearly, vividly remember one of the first days taking vitals on a patient who had passed away, and I didn't realize that person had passed away because they were mechanically ventilated. And that was the first time I had realized, actually putting together, that the lungs are still being pressurized even long after the soul has passed. I was providing direct care to patients from my community at a time when my community needed me most and still needs me. My unit was designated as a COVID floor. I'm proud to say that during this time, I had the privilege of learning from and working shoulder to shoulder with some of the best nurses in the country. Although in no way was I prepared emotionally or physically, I was exposed to treating patients on isolation precautions because of my clinicals at Lehman. So I felt confident in donning and doffing PPE. Additionally, during my rotations, I treated mechanically vented patients, which included trach care and administering enteral feedings and medications. This exposure during my clinicals was so crucial because I was now responsible for administering care to this specific population. Oftentimes on the floor, I'm the go-to person for the doctors when they need help with something. They usually ask, how long have I been a nurse? And I tell them it's just been a few months. They're always surprised. And in large part, I feel that confidence I have on the floor is due to the training that I received at the nursing program at Lehman. More than just didactics and technical knowledge, Lehman instilled confidence in me, and that confidence is critical to put those skills to use. Thank you.
Excellent.
Before I go on, I have to tell you a real quick story. I taught a course called Community Health Nursing way, way back. Her brother and her sister would sit in the back of the classroom. Their mother was my student, right? I would then say to students, so which one of you can tell me what's going on and give the stuff? The 3 of them would be raising their hands because they listened to every word that we said in that class. We're so proud of Kesha. She came back, almost 20 years later to our nursing program. Her mom's a graduate of our undergraduate and professional program. Thanks, Kesha.
Thanks, Kesha. That's excellent.
Great job.
I'm actually going to piggyback on that a little bit and turn this question over to Dr. Georges. How do we, as a college, work directly with the community at large? You just talked about that a little bit. So how are we intentional about working with the community at large? What do you see?
Intentionality must be a strategy. We must make sure that we engage in the communities that we provide services. We've got to make sure that the people in the borough of the Bronx understand that we are a community called Lehman College. As I look at Michael Sullivan, who's been around and know what we've been doing over the years, and keep happening from psychology, who understands. We reach out to the community. We provide services through our clinical courses in nursing. Other of the institutions provide services, out of the services in the colleges, to the students so that they can be shored up and enhanced in their learning and in opportunities that they could have. Lehman College, if it must be the catalyst in the borough of the Bronx to change the horrible health indices that exist, those indices do not just come from us who are in healthcare, but we've got to make sure that we are out there pushing to be sure people have decent housing, not because we're going to get in our cars and go home. We got to be sure there's decent housing for our citizens in the Bronx. We got to make sure the schools are up to par. We got to make sure in our communities we have decent places for people to play and for them to buy foods. That's our role as a college. We have got to step up and step out. I think we've begun the job. We've been doing it. Now we got to make sure we continue to do it. And if nothing else, this COVID-19 has made us so vulnerable. But not just that, it has identified how we have got to depend on each other for our continued survival.
Thank you for that, Dr. George. I appreciate that. And as we know, almost 50% of people in the Bronx in April and May were tested positive right in this zip code in Lehman, which was very interesting. I'm gonna turn to Dr. Martin and Pauline. This question is for both of you. We know Dr. George just explained that what COVID-19 has exposed us to health, education, economic, and racial inequalities. But so as other significant events in our history, right? We notice, but somehow we keep putting these issues back on the shelf. How is this moment different from any other moment that you've seen? I'll start with Dr. Martin first.
Thank you. So with COVID-19, it was an eye-opener in the sense that it became a community problem and then a global problem. And no matter the money, the education, or your zip code, you could not be protected from COVID. So everyone was impacted. And then it became a situation of if your neighbor is living a certain way or the people down the street live in a zip code and you can avoid going through that neighborhood, that's fine, you don't have to deal with it. But now you have a disease or a virus where if they're not well, you're not going to be well. So, and if they don't have testing sensors so that we can try to mitigate the effects of it, then it's going to impact everyone. So I think that's what kind of catapulted this into we have to do better. And in addition, COVID didn't spread on a level playing field. So structural racism, which is embedded within the fabric of American infrastructure investments and public policy, and which fundamentally drives in inequities, this same racism has driven the systematic dismantling of the American social safety net and also the policy recipe for American structural vulnerability to the impacts of this and other pandemics. So the Bronx provides an important case study in investigating the historical roots of structural inequity showcased by the pandemic. So, and the current lived experience of Bronx residents. So I think this is why, even though we've had all of this, COVID really spotlighted this. And then on top of the fact that we had the now infamous killing of George Floyd, it's like, so we're fighting this virus that impacted brown and Black people negatively. And that's something that we cannot really control. But then it was buttressed against the racial inequality. So now it was like, you know what, we got to change things. So I think that's why this movement is different.
Thank you, Dr. Martin. Pauline? Your mic is muted, Pauline.
Yeah, I just wanted to add that what makes this moment different is that we're all affected. You know, it's not just Black, white, Hispanic, you know, just young, old. We've all been affected, and the covers have been lifted off of all these, you know, or the, you know, these wounds have been opened up, and so we're able to see now what's really under there. Some people weren't able to see that before, but now we can see that it's not just talking about racial disparities, inequalities, and it doesn't exist. You can see the effects that it's there, but this is highlighting it. You know, this moment is different because, you know, I believe now that we're able to see these things, we are actually going to try to do more to address these issues. You know, at least I'm hoping so. I'm hoping it doesn't get covered up again and, like you said, put back on the shelf. But I think this has really opened up people's eyes.
One of the other questions that I like, Darell and Pauline, because of where they work, when it comes to treatment, and do you think there's been age discrimination during this pandemic? Darell?
Well, from what I experienced as a nurse, seeing how my patients were regarded, as well as seeing our country's response to the pandemic, I can fully attest to the statement that ageism played a role in shaping the care that the elderly received. There were many logistical and political reasons, especially in nursing homes, how they were managed. Initially, we were told that COVID was really only dangerous to the elderly. And this was ageist because medical and American culture both overlooked how the virus was actually taking a toll on individuals with comorbidities, those who were immunocompromised, those who had underlying health conditions. Coincidentally, the elderly fall into many of these categories. But what we really saw was protocol being implemented and guidelines that were issued that were mostly geared towards children and adults. Elderly specific protocol for managing COVID hasn't really been a focus. Instead, elderly were kind of grouped together with adults, despite the fact that physiologically disease processes may affect elderly differently. And something such as body temperature, which runs lower in the elderly population, a temperature reading of 99 would indicate a fever, for example, and this wasn't even recognized. COVID really took the world by surprise. And I think we looked to see how other countries were responding and addressing the virus. I don't know if you guys remember, but the health minister in Ukraine, he publicly stated that if you're over 65, essentially you're a corpse. We saw Italy respond to COVID by saying the cutoff age for ventilator support was 65. Even in our own country in Texas, Lieutenant Dan Patrick, he publicly said, if you're 70 years of age, you need to sacrifice yourself for the good of the economy. In Florida, I'm pretty sure you guys saw the viral clip of the spring breaker who said, if I get corona, I get corona. And it was as if he felt he was invulnerable and didn't care that when he returned home, he would be placing his grandparents at risk. I'm not sure how many of you are on social media, but when the pandemic first started, there was a tremendous coverage of a viral hashtag, and it was called #BoomerRemover. I wasn't aware of it, but residents at the facility I worked at mentioned it to me, and I knew it bothered them. In New York, the nursing homes, they were affected because we were told to take in COVID patients from hospitals who were running low on beds. So for a period of about 3 weeks, we accepted patients who were positive with COVID and put them at risk and put our own elderly at risk. But you know what, I can say right now that New York, they have ventilator guidelines where they're not based on age, they're based on clinical factors. So that's good. As far as telehealth, the elderly aren't equipped and tech savvy to do their appointments virtually. They require a lot of non-essential medical services, such as podiatry, dentistry, physical therapy. When they're forced to go without these services, dentition, for example, would be affected. They're not going to be eating and just be overall at risk for long-term complications. But you know, I know I'm going on really long. I just want to lastly point out that the elderly population is really the backbone of the volunteer sector. And we saw retired nurses and elderly return to the workforce to lessen the strain on us. However, due to basically an ongoing intergenerational divide, our response to the pandemic really didn't honor them in that same regard.
In addition, I just wanted to add, Darell, that in the hospitals, as patients got sicker and more ICU beds were needed, you know, in triaging a lot of these patients, the decisions were made to ship some of these patients into nursing homes. and that really affected, a lot of the increased the death rate, among the elderly going to these nursing homes. Also, there was increase in DNR orders. I don't think I've ever seen as much DNR orders, during, any other time like now. And in one hospital I was reading, I believe it might have been in, was it Brooklyn or Queens, that they were forcing patients to sign DNR orders, so it has affected the elderly, absolutely. And there has been age discrimination during this pandemic. The elderly are, at risk because of their comorbidities and, and they really need people to advocate for them. And I don't think during the pandemic they had someone to really advocate. A lot of them were pushed to the side because of their age,
Thank you, but I do want to say one thing, and this is in my past role as president of AARP. Darrell's right, Pauline's right, and somebody had to put it out into the media and the public. And I salute AARP for going after these states and these governors and these institutions who totally disregarded people who are 50 plus, because people, as he said, thought baby boomers like me should be gone.
Okay, Dr. Georges, I'll take this question. I'll take the next two questions. And I'll go to Rosa and Darell for this. How do we get more, and let me start with Darell. How do we get more men and Latinx into nursing? So I'll start with that, Darell. How do we get more men into nursing?
All right, so in order to get more men and Latinx into nursing, we have to first understand that the patient population is becoming more diverse, and the inclusion of more minority nurses can address a large variety of concerns and conditions in which we're presented with. In order to get more men and Latinx into nursing, I feel that there needs to be more awareness into what a nurse does on a daily basis. Unfortunately, it took the pandemic to really illustrate how valued the nursing profession is. Many people didn't understand that our critical assessments are crucial to guiding the plan of care. We didn't just implement orders, we evaluated and determined what worked, and we made suggestions based on clinical presentation. I think sexism plays a role where nursing may seem more effeminate because of the compassionate nature. However, male nurses can provide a different perspective or just be more comfortable with male patients. Gender bias plays a role because stereotypes may prevent men from wanting to join the nursing workforce. And I think us as nurses, we should just encourage men and Latinx to consider joining the nursing profession. We need to align ourselves with organizations like the AAMN, the American Assembly for Men in Nursing, as well as nursing schools to generate greater outreach to the community, just explaining the benefits and rewarding nature of the nursing profession. Before the pandemic began, the World Health Organization said that this year was the year of the nurse. And it wasn't only because it was the 200th birthday of Florence Nightingale, but it's because the profession is getting more notoriety and acceptance as a valued member of the healthcare team. So I think we should really build on that.
Excellent. Rosa, do you want to add your input?
Well, he said everything I was going to say, but okay. I think a lot of outreach programs we can go into middle schools and high schools and try to get these kids early on and expose them, like maybe tours of hospitals, or let them do little visits where we can take them into the hospital and see what a nurse actually does, male and female. Going into neighborhoods, disadvantaged neighborhoods where people probably don't know what is it, everybody thinks a nurse is just cleaning and bedpan. Just let them know that it's much more than that, and that it's a rewarding position, and it's helping people. Social media is another way to get through them. Everybody's on social media today. You got all these young kids in social media. So I think if we can do that, we can get people interested in nursing, because we do need more men and females, Hispanics in nursing.
Yeah, and I agree with you, Rosa. I mean, you can't be what you can't see, right? So the more you can see it, the more you have this opportunity.
Well, they need the exposure, maybe what do you call it, commercials about nurses, what they do.
Right. No, I agree. I agree. And we're going to get into questions in about 5 minutes. I want to ask Dr. Georges, simply because you've seen Kesha when she was a young girl in a classroom, and now we see her with this background in front. So that must be incredibly rewarding to see that, and it must be rewarding for you too, Kesha. So, Dr. Georges, where do we go from here? You've seen the landscape. What do we do from here?
Where do we go from here? One, I think Rosa, Darell, Pauline, Lellanie, Kesha has said it, maybe not in the same way, but the key is we need to promote the role models that we have produced in Lehman College Department of Nursing. We need to stop worrying about all the ones who are problems and concentrate on these heroes and sheroes. I mean, when I saw Kesha's note to us about what she was thrust into, when I talked to Darell while he was sitting in his car one night after work, I say, we have got to tell people, one, nursing is about human caring. That's what it is. And that means every aspect of a human's life. Nursing, I think Rosa said it, Darell said it, Lellanie said it, Pauline and Kesha. Nursing is knowledge work. It is not rote. It is not just psychometric skills. You know, I mean, we can teach people how to do things. We teach patients how to give themselves injections. That's not the only thing we do. It's what we've got here in our brains, how we plan, how we feel what we need to be doing to change indices in communities, to build and do something. Where do we go from here? We need to come out strong. As I said at Lehman College, we're going to continue to do it in nursing. Now, a department, I look and see some of our faculty here, some of my doctoral students here on this call. They're the leaders. They're the ones who are telling everybody. We've got them spread out in institutions, working as liaisons with these hospitals. Dr. Lancaster is working with Bronx Care. Dr. Dobson is working with St. Barnabas. We've got Dr. Joseph down at St. Luke's Roosevelt. We've got Dr. Lundy over at the VA hospital. We've got those folks out there who are really, really building and being role models and exemplars of what nurses from Lehman can do and how we can change the care that's being rendered. And particularly in this borough, I'm going to say it again and again. We are number 62 of the 62 counties in this state. It is an awful shame that we continue with this. But I will say to you, and I'm sure the faculty in the Department of Nursing and the students and the graduates will tell you that they're ready to do something about that. They've got the skills, they've got the knowledge. All we got to do is get them to run for public office so we can get them to change everything else that needs to be changed. And we will make sure that it happens.
Yeah, and thank you, Doctor. And I agree with that. I mean, it's so ironic how we continue to be in 62nd place for the last 10 years. But we got right on 161st Street. We have the Yankees that continue to be in first place. So it's just so strange how that whole thing happens. And if the Yankees were ever in last place for 10 years, the whole city will go crazy. So we have to have that same passion that we have for sports for ourselves. So thank you very much for that. I would love to hear from anybody that wants to ask questions. You can put it in the chat. Please, we got about 10 minutes before we close out. So if anybody has any question, or they can raise their hand. If I can find their hand, you can just come off of mute and ask the panel a question. Maybe that's even.
I have a question for the professors.
Sure, let's go.
How has, from last semester when you were teaching in person to Zoom teaching now, how has that changed your methods? And do you feel that the students are getting the same kind of structure from in-person classes versus like online?
It's not the same. It's never going to be the same. So what we need to come to grips with in nursing education, the world has changed. The old techniques have got to be reviewed. We've got to learn and figure out a way to deliver content to the persons in using different strategies, different technologies. You know, I have to tell everybody, and I'll say it, and I don't want any of my other colleagues from Lehman to get upset, but the nursing department faculty rose to the occasion. You have never seen such a bunch of folks who all of a sudden were out there. They knew everything about vSIMs, DocuCare, every piece of software you could ever figure out. I didn't even know some of them existed, but you could not believe what these men and women did, you know, in making sure that we didn't drop the ball, that we try to make sure that students, even though they couldn't physically be with patients, that we were able to give them what we thought they should have. Now, it was hard for the students because they're not used to that. They were used to being with patients. We were shut out of hospitals. The hospitals wouldn't let us in. But I think we rose to the occasion. And just to tell you that, our students graduated in May. They graduated. And many of them have already taken the boards and passed. So we have to have done something okay. Now, I don't ask you, I see some of the junior students are on, the senior nursing students are on. I don't know what's going to happen. We've got to track that, Kesha. We've got to look and see what worked, what didn't, and how we can change it. And the faculty is right on top of it. Our faculty is on top of this.
Thank you for that, Dr. Jones. I actually have a question. I think this is a question a lot of people in the public and we hear it on the media, and I'm certainly concerned personally, but there's often this conversation about you can catch COVID twice, and here we come up on the flu season, and so how, you know, what's the preparation? Is that just media? Is that just trying to scare us, or is that real? And anybody on the panel could be my guest to answer that question.
Lellanie, you want to take it?
Take it.
Sure, absolutely. So that's a very valid question, seeing that COVID is new. So COVID is a virus. So initially you had the people who became infected with COVID-19. And then after that, they did the antibody check. And then people were saying, oh, I have antibodies, so I could be immune for COVID, which is not true. So just because you've had COVID before does not mean that you are immune from getting COVID again. So it's still new, it's still being studied, and it's still possible to catch COVID. So everyone should wear a mask, wash their hands, and self-isolate as much as they can.
Yeah, there's another question, Lawrence, from Adita Vera Cruz.
Sure, I just saw it. Thank you, Robert. Ms. Cruz asks, if you were in charge, what would you do to make work environment a better place to work? Dr. George is signaling for somebody to answer the question outside of her. You're muted.
I'm looking at Darell because I know some of the problems he had, you know, and Anna and Kesha. So why don't you folks speak?
Well, what I would do is have everything be fully transparent. We need our employers to work alongside the Department of Health and follow guidelines that were set forth to make sure everything is safe for the employees. You know, the employees are really the ones doing everything. And if we don't have equipment, if we're running out of hand sanitizer, bleach wipes, hand soap, if we're running out of these things and we're responsible for bringing it in ourselves, you're not going to have a strong workforce. You're not going to have a workforce that wants to come in and do their job. You have to make sure your employees are happy. You have to listen to their concerns. And just in order to make the work environment a better place to work, it just really comes down to transparency and listening to what your employees have to say.
So my facility has started to address these concerns. So graduating from a public university and
You're muted.
Sorry. So my facility has begun to address some of these concerns, and graduating from a public university and transitioning to a public health hospital, I feel that the standard and quality of care is improving. I wanted to work for a public institution because I believe in public access to healthcare. So my facility has instituted courses like the basic critical thinking course, basic ICU intensive course for like med surg nurses to get some ICU skills preparing for the second wave. They've also increased their supplies. We haven't had a shortage of masks or supplies. Our environmental cleaning staff is phenomenal. Everyone really works together, and administration has meetings where they do address our staff concerns. Our DON always keeps us in the loop. She comes to the floor. Our ADNs are amazing. They really do keep us up to date on how we can best protect ourselves and new protocols. Granted that during COVID, from March to April, I don't think anyone was prepared for this. They themselves were just learning how to deal with these new interim rules. So I feel like our institution and our facility has really gotten a handle on it, and they are improving. I do feel like it's a safe work environment, and I do feel confident that when the new nurses come in, they're going to be adequately trained as well, not just put on the floors.
I just have to do a shout out. The chief nursing officer at Jacoby Medical Center is a Lehman College alum. So if you want to talk about,
see, I knew something had to be.
Susan Panacho is a Lehman College graduate from our RNBS program. So, you know,
that's awesome.
That's, you know, the tone at the top.
Yeah.
Over there. And that's why they're doing a good job.
Yeah, she really is. As I said, it was difficult for everyone in the beginning, but I feel like the hospitals have definitely improved. I know my facility and Health and Hospitals, they keep all employees updated through weekly emails and meetings. We also are offered wellness and helping healers heal therapy. So there is that improvement to the work environment.
Can I just add something? I wanted to say, nobody mentioned the flu vaccine. People should be encouraged to get the flu vaccine, staff members, everybody, family members, because they're gonna run out soon. I see a lot of people coming to the clinic getting the flu vaccine. And I'm hearing from my students that the flu vaccines, they went to 4 different places and they had run out. So that's very important to encourage, especially the elderly and the people that are out there in the front lines, that they should have the vaccine. And testing is key. Everybody should get tested. If they can, they should get tested.
Excellent. Thank you for that, Rosa. I have one more question, and I think there's another, and I'm sorry if I can't answer all the questions. We can't get to the panel, all the questions, but another big question was, do you think we open back too soon? And I know New York has been incredibly cautious, but overall, do you think we're opening up too soon? I'll leave that open to the panel, whoever wants to jump in on that. Dr. George is saying somebody get it for her.
Can I say something?
Hey, Rosa, go for it.
You know, whether you open up sooner or later, it doesn't matter. People are doing what people are doing. So I don't think, you know, people are still, we see a lot of people that are being very irresponsible. You go outside, you see them in parks, they're not wearing masks. I see staff members sometimes that don't put the mask all the way up. They just cover the mouth and not the nose. The hand washing, I mean, there's just too many factors to answer that question and say, yes, because even if we open up, let's say in December, you're still gonna have those people that are irresponsible. You see them on the buses and on the trains with no mask on. So how do we do that? How do we control that?
Right, and
What's
then
the problem?
Yeah, I agree with you, Rosa. And then let me just bring a little further. So what do you think the impact since school has just opened up? So if the panel can just kind of elaborate a little bit on the impact of school opening up and children going back to school. And I know, Darell, you talked about it a little bit about, you know, young people being able to catch this disease as well.
Yeah, so.
And I know you have 2 kids, Darell. I know that you have 2 kids too, so I know that's important.
Nephew and niece.
Oh, okay.
So my sister-in-law, she's actually a school teacher. And one thing we were all concerned with as a household is what's going to happen when she returns to go back to work. children, no matter what you do, they're going to be anxious to get back to see their friends. They're going to play with each other. They're not going to recognize the social distancing guidelines. They're going to play and do what kids do. You can't expect them to wear a mask if ourselves as adults get irritated with wearing a mask for a prolonged period of time. I think with saying school opening too quickly, I'm on the fence about it. And a lot of conversation really corresponds to the economy, people wanting to get back to work, as well as people not having babysitters or just unable to do that remote learning. But for me to actually agree with if we open too soon or for public schools, my personal opinion, I think we should have went until January. And in January, then go hybrid. But that's just how I personally feel everything is going. But I guess time will tell and we'll see, because we're currently spiking a bit. We're still at the 1%. So time will really tell and see how well we're doing.
Just to piggy off Darell, I completely agree with you. I do feel like we did open too early, schools and restaurants and everything. So COVID-19, the RNA protein sheds every 28 days. So that reactivating factor for COVID, for the virus, it's going to take months. Like there's research that's coming out about how it's affecting children, and not just children, but different aspects of the body, from mental health to, cardiac and your respiratory system. So it's still a developing disease. And just because it now has been seen as to reoccur every few months now in former COVID patients, I feel like it was too soon of a decision just because the research hasn't been completed.
Excellent. And Dr. Martin, I'll ask you for your perspective.
Yeah, so I think it's very interesting because you can sit back and kind of watch it and we can all lend our opinion to it, but we don't really know, and this is new. So from what my experience is, it's combined. So for instance, when I look at the individuals that I've even worked in a COVID center, and when the individuals I work up with come up positive, it's usually not from the patients at the COVID center because they've used the correct PPE and precautions. It's usually from the people who have decided that they wanted to go to that family party or the wedding that they were supposed to go to. And then initially when we started, it was like, when we were all scared at work, it said, really, you're more at risk during the community spread. So no matter what, people have to do their part. So I've had my sister who's in education go back to school in Florida, and it's starting to spread slower. You've got college students who are back, but again, it's the age group. Again, they're not getting it at class. It's this off-campus party or where they snuck to see their boyfriend at another school. So I think this is where it's coming to light on community responsibility, and taking care of yourself is taking care of one another, which is the bigger social issue. So COVID is one thing, but then you have a lot of selfish people out there. So it doesn't matter when we open back up again. So it's kind of those things where you just have to protect yourself, but there's really no right answer. And, there's money, there's society, and those things fuel everything. And unfortunately, some people are going to pay the cost, and that's why we have to protect ourselves, because the leaders at the top and money, economy's got to get back going. So we have to do the right thing. And if you don't feel you need to go out to a restaurant, don't, and then protect yourself.
Right. Thank you. And I appreciate the whole panel. I'm going to close this out. We have a minute left. I just want to say, as we close, first, thank you to the panelists. And as we close, I challenge you to think of ways you can give back to this university to whatever degree you're comfortable with. And I don't mean just monetarily. I mean, though, of course, this is always welcome. It's very, very much needed at Lehman. But there are other ways that you can give back, from career and academic mentoring, from volunteering as a virtual speaker or panelist, or just simply attending academic and social relevant events like this. I always say, just remember that it doesn't matter how much you give, but the fact that you give, that really makes a difference. So let's just continue to pour our support into each other and work in ways that will continue to make us proud to be Lehman alumni. I'm proud to be the president of the Lehman Alumni Association and have a great and dynamic board. So please stay safe, be well, and I truly, truly appreciate everybody's time. Thank you very, very, very much. Take care.
Bye.
Thank you. Have a great day.
Take care.
Bye.
Bye.